Bismillah ar-Rahman ar-Rahim. Welcome to ERA. I'm Dr. Muhammad Talat, Assistant Professor of Radiology at University. I hope you enjoy our course. This is our first case today, an adult patient who is presenting with acute neurological deficit. The cross abnormality in this case, this hypodense area, hypodense patch area, cortical and subcortical in location, involving the right frontotemporal region. So we have here the first point, hypodense area. Second point, mass effect. We have an effacement of the cortical cell side on the right side as compared to the left side. The third point that we have, if we go more to make like stroke window, as we discussed in the last video, the insula here on the right side appears hypodense as compared to the contralateral side. So we have here insular ribbon sign, and also we have here hyperdense MCA. This is the right metacerebral artery. This is the insular part. So this one is M2 segment of the right metacerebral artery. It appears hyperdense as compared to the left side. Even the distal branches appears hyperdense as well. So we have here 4 signs which is suggestive, or which are suggestive of acute cerebral infarction along the territory of the right metacerebral artery. The fifth criteria for acute ischemic insult, the basic ganglia, I think it is more or less preserved. We need to discuss more the pathogenesis of the cerebral infarction. Cerebral infarction is characterized by cytotoxic brain edema. We have different types of brain edema. One of these types are cytotoxic brain edema. What happens in the cytotoxic brain edema? Let us imagine what happens if we have here the cells of the brain, and this is the extracellular component. This is the movement of the water in the extracellular component. Once we have cytotoxic edema, the cells appears markedly swollen. And the extracellular water will find difficulty to pass between the cells. So we have here 3 points we should emphasize. The first, the water movement appears more difficult. So we have here restricted movement of the water in the extracellular space, and this one can be demonstrated by restricted diffusion in the MRI sequence, in the diffusion with image, as we saw in the last video. The second point is these cells are compact cells because they are swollen, so the edema appears fairly defined or sharply defined, as you see here. So the second point is a pattern of this edema. The margin of the edema is fairly defined. The third point here, one of the most important points, that the cytotoxic brain edema affects the cells in the gray matter and in the white matter. Again, the edema will affect the gray matter and white matter. So the gray-white matter interface will be lost. So once we have edematous gray matter and edematous white matter, so both of these layers will appear hypodense together, so the gray-white matter interface will be lost. The last point that we need to emphasize here is that the blood-brain barrier is still preserved, and it is not disrupted in the cytotoxic brain edema. It's very important to know what is the cytotoxic brain edema, what is the pathogenesis, because it's very important to check Is it cytotoxic brain edema or any other types of brain edema? Cytotoxic brain edema more commonly detected in the acute ischemic incident. We have also, in this case, small hypodense areas, subcortical in location at the left frontal region. And its density is much lower. So most likely these are small chronic lacunar infarcts. Let's move to our second case. Young adult patient who was presenting with acute neurological deficit. In the left high parietal region, we have hypodense area. And this hypodense area is characterized by finger-like projection. Also, it is characterized by preserving the density of the gray matter. So the gray matter is spared. So the hypodense edema pattern involving the white matter only, while the gray matter is still preserving its normal density. Also, we have here the hypodense edema is characterized by ill-defined outline. So we have here three criteria: finger-like projection, and the edema involving the white matter, while the gray matter is spared. The last point is ill definition of the cerebral edema. So we are dealing with a different type of brain edema, which is so we are dealing with a different type of cerebral brain edema, which is called vasogenic brain edema. Vasogenic brain edema is characterized by a leak of fluid from the capillaries into the extracellular spaces. If we need to draw the cells of the brain, and this is the capillaries, the water will leak from the capillaries to the extracellular space. So the first point, we don't have any diffusion restriction because the water is moving freely between the cells. So we have here facilitated diffusion, or we have no diffusion restriction. Second point, this process involves only the white matter. So the gray matter is preserved. So the gray white matter interface will be preserved. The third point, this edema is characterized by ill-defined margin. To start the process, why there is a fluid leak from the capillaries into the extracellular space? Because the blood-brain barrier is disrupted. So again, once we have any blood-brain barrier disruption, the fluid will leak from the capillaries into the extracellular spaces. The cells are not swollen, so the water is freely moving between the cells, so we don't have any diffusion restriction. This pathogenesis or this process involves only the white matter, so the gray matter will be preserved. So the gray-white matter interface will be preserved. This edema is characterized by ill-defined margin. Once we have any vasogenic brain edema, we should search for any underlying space-occupying lesion, either abscess, either brain tumor, or cerebral abscess or metastasis, any space-occupying lesion. Okay, so it's very important to pick up and to be sure, is it vasogenic brain edema or cytotoxic brain edema? Cytotoxic brain edema indicates that we are dealing with acute ischemic insult. Vasogenic brain edema, this needs further assessment with IV contrast. it's better to move or to better to make contrast enhanced MRI study for the patient, or at least contrast enhanced CT scan. So it's very different pathways. Plane for the same patient, I need to demonstrate more the vasogenic brain edema. As you see here, it looks like finger-like projection, and at the same time, the gray matter is preserving its normal density. So we are dealing with vasogenic brain edema, and this is considered one of the red flags that we need to continue with IV contrast. Either it's better to be contrast enhanced MRI study. If we don't have any chance to do MRI exam, it's better to do contrast enhanced CT scan of the brain. So please, one of the great mistakes and common mistakes, especially for the juniors, once we have hypodense area like this one, please don't diagnose this one as acute cerebral infarction, because this one is totally different. This is considered as vasogenic brain edema, not cytotoxic brain edema. We have the main two types of the brain edema, cytotoxic brain edema and the vasogenic brain edema. Also, we have the third type is combined between cytotoxic and vasogenic brain edema, and it is commonly seen with venous cerebral infarction. We have also another special forms for brain edema, what we called transependymal brain edema. This type of edema occurs in cases of obstructive hydrocephalus. The fluid will move from the ventricles, or the CSF will move from the ventricles across the ependymal lining of the ventricles into the white matter of the brain. So this one is considered as retrograde transependymal CSF permeation, and you will find some brain edema, periventricular invocation, in cases of obstructive hydrocephalus. So these are the most common types for brain edema.
We did contrast enhanced MRI study for this patient, and this exam will be discussed in details in next video, inshallah. I hope you enjoyed our teaching cases today, and thank you so much.